Okay, we're going to go ahead and get started. Please help me welcome Dr. Jose Rubero. Dr. Rubero received his medical degree from Central Del Caribe School of Medicine in Puerto Rico, where he later designed a medical student curriculum in emergency medicine. He was appointed associate professor, moved to Florida, where he joined Florida Emergency Physicians Group as an emergency medicine attending for the Florida hospital system in Central Florida. His goal is to integrate the emergency medical curriculum as part of medical school's curriculum. Interests are in cardiology, pulmonology, and critical care and EMS. He presently works at Osceola Regional Medical Center. He's here to talk about EKGs and changes that can kill you. So, thank you.
Okay, good morning. Like they say, I'm Dr. Jose Rubero. I work right now at the Osceola Regional Medical Center. We started a new residency 2 years ago with the University of Central Florida. So that was one of the reasons I transitioned from Florida Hospital to Osceola Regional. Right now, we start this new residency. We're going to our second class this coming year. We are doing a great job trying to do basically different stuff, trying to put everything in Osceola more up to date. In view that you have a residency program in a community hospital or a hospital that has been going on for a while, is a new hospital, old hospital, community hospital, sometimes they don't have the up to date. So because you have residency, everything has to be more apart what is going on nationwide with medical treatment. Now, the topic we're going to talk is EKG and ST changes. There's a lot of electrocardiogram. Many times you're trying to figure out, does the patient has a STEMI, the patient doesn't have a STEMI, chest pain, no chest pain, do I believe the patient is faking, or like Dr. Banerjee was talking about anxiety, hyperventilation, and the patient has a panic attack. It's difficult to say really which type of EKG I should believe. Does the patient really have an ST elevation, or the patient has an MI, or something like that? There's no way I can present this in 1 hour. I just going to divide this topic in two. I have a topic with you guys today, and then I have another topic with the EMS on Thursday. Right now, I am also the assistant medical director for the Osceola County EMS, so we'll have something similar to what you have here this coming Thursday. But like one of the new things that I try to do is there was some question. We're going to post a poll where you can use your cell phone, and through your cell phone you can answer some of the questions to see, okay, let's see what the majority of you guys think about certain type of EKG, and then we'll discuss it. There's no way I can discuss every single EKG in the sense of the pathophysiology, why you have ST changes. But what I will try to show you some basic waves, changes, or forms of the EKG where you can figure out, maybe this is not true, or maybe there's something wrong with this patient. So we'll try from the basic, and then we'll go a little more complicated, okay? So, this is my website. It's Florida EM Clerkship. It's a free website. On this website, believe it or not, you can go in and you can see my lectures. You can review all the lectures I give to the residents, etc. So you are welcome to open and follow the presentation there, or you can see other presentation and videos. So, disclosure, I don't have any disclosure. I'm not going to sell you anything. Just the only thing I'm going to tell you is, you need to read your EKG and learn more. Every year, you're going to learn new stuff. It's like when I was doing this presentation, I went recently to Cuba 2 months ago, where I did this same presentation. I was reading different papers about it, and then you'll see some EKGs that, there's something new that I was not aware. So every time that you read, you will learn something new. Objective, well, try to recognize some different EKG and ST changes that it can suggest not only for heart attack, it can be suggested for hyperkalemia, it can be suggested for pulmonary emboli, can be suggested for pericardial tamponade. It's not only we're going to focus on MI, we're going to focus on other type of disease per se. Recognize a typical EKG presentation, recognize condition that EKG changes may mimic an acute MI, it really is not. Okay? So, let's go with the basic, and then we'll go, like I said, a little more complicated. So, when you see an acute MI, usually the EKG presents what they call a convex or a straight ST elevation, or believe it or not, if you go Google, Google, and you look Dr. Google, like many patients come to the ER, well, Google said I have this. So there's something called frowny face. The frowny face is like a sad face. What you're looking to look is something like this. So if you see something where the ST elevation, the face, the mouth is like this, then it's something you have to worry about. Versus when you have something called benign early repolarization, you will have that a happy face. A happy face, you will see that the ST elevation, you will have a smaller face. And I'm going to explain to you a little bit about this. Okay? In pericarditis, one of the indications in pericarditis is diffuse ST elevation. And usually when you have pericarditis, the patient, when he has ST elevation, is in almost every lead, but there's no reciprocal changes. And in addition, have what? The happy face. Okay? Any Bodmer-Browns block, you will have a concave ST elevation. And usually, if this patient is not presented with an MI, we will have a smiley face. And again, you will see what the different EKG I'm going to present to you is like, not most of the cases will show this, but if you see something like this, where you have the sad face or the smiley face, you can try to figure out, really there's something wrong or not with this patient, okay? Sometimes you will have a left ventricle aneurysm, and usually these are the patients that have an ST elevation MI last week, got a heart cath, and after a heart cath, they go home, and then they come back 1 week later where we have compared chest pain. And when they have the chest pain, you repeat the EKG, and the EKG you will see that it has ST elevation again. And these people, what happens, the ventricle, especially the left ventricle, has a hole there, inside there, and has an aneurysm. And if we have time, I will show you some pictures about this type of patient. So, again, just to recap, remember the frowny face on acute MI. We had the benign early depolarization, usually a happy face. You will have a Bodmer-Browns block where you have a smiley face at the left ventricle aneurysm. Let's go a little bit about the EKG changes. As you can see here, we have around 20 type of EKG changes that we will try to discuss. And of course, there's no way in this short time to present all of them. But we'll try to figure out, start from the beginning, and let's see how the time goes. So the first one, so you have the typical EKG presentation where you have the normal ST morphology, you have the early repolarization, and the normal variant. And all of them, what they have is, just use your imagination, the smiley face here, okay? You have the smiley face here, okay? So usually this type of patient may not have an MI. Now, we'll see the other type of cases where there's something abnormal, like a brugada. We will have a patient who has an MI. Patient may have a cellular aneurysm. And you see that the face, the smaller face, is not there. Now the face is a frowny face, where it's a sad face per se. Okay? And we'll try to discuss a little bit more while we present some of the cases. Okay, so this is the first EKG. We have this patient, we have an EKG. This is an EKG that is from one of you guys, from EMS, that they brought comparing chest pain, and then they're trying to figure out does the patient has an ST elevation or not. Okay, so he will go with it's called early repolarization. Okay, this will be the same patient where we have the same presentation, but we repeat the EKG in the ER, and the EKG, this is what it shows. Okay, so trying to figure out, look at the EKG, and then let's see if you can do this. Let's see if we can get activated. Sorry, bear with me 1 second. Well, looks like it's not working. Sorry, but so of this EKG, which of you guys think is going to be an ST elevation or not? Okay. Now, supposing you guys are going to take your cell phone and there's a phone here, and you're going to put, and they will have like how many of you guys said yes or no? Now, just going back again. We'll see this same EKG where you have little bit of ST elevation, but they are diffuse. But what's two indications that it's less likely to be an MI? There's no reciprocal changes, one. The other thing is this happy face here. Okay, look at this smiley face here. So it's less likely to be a ST elevation MI. Again, the same patient. So this is what they call early repolarization. So what is early repolarization? So early repolarization usually is non-S elevation. You will see this type of patient where you have an increased J point. When you have an increased J point, usually you will see in people who are very tall, African American, very skinny. And usually it's a morphology that is normal. It's a normal variant on EKG. And as you can see here, that's the J point where we're talking about, where you have a smiley face here. It's not the sad face. These are different type of EKG showing the same stuff, okay? Smiley face. And the other way that they can call it is called the fish hook or the J point, okay? And the fish hook, and the reason they call it fish hook is because this area here looks like a fish hook. Again, medicine is a lot of imagination. This is the second EKG about another patient that presents comprehensive chest pain. The question is, does the patient have an MI? Does the patient have something going on that is causing his chest pain? Okay? This is another kind of early repolarization. The difference between the first one and the second one, this patient is more tachycardic. And because it's more tachycardic, the ST looks a little more elevated, but really does not show reciprocal change on this patient. This is another case where you will see a typical, again, African-American guy, maybe overweight, and is complaining of chest pain, and this patient usually will have a blood pressure of 220 over 100, and the complaint is, oh, I have a foot pain, and you did an EKG back in the ambulance, and then you see something like this. But the patient is not complaining of chest pain, it's not complaining of shortness of breath. The other thing is the blood pressure is very high, and because the blood pressure is very high, you decide to do a 12 lead, and you see something like this. Okay? And again, suppose that you had to answer the question, but sorry, it's not working. This is what they call LVH. Well, this is LVH, left ventricle hypertrophy, where you see that when you have the left ventricle get dilated because of the chronic hypertension of this patient to be dilated on this part of the ventricle, it making that the wall get thicker, and because it's getting thicker, you will see the J points getting bigger and causing a little bit of S elevation. Okay? So again, LVH get thicker, the voltage of electricity causing this wide QRS, and depending what book you read, there's something you can check the QRS, usually on V1 to V3 if the S is more than 35, or in V5, V6 if the R is more than 30, usually it considered a LVH, or left ventricle hypertrophy. The most common thing that causes left ventricle hypertrophy is hypertension. Okay? So this is what I'm trying to figure out about the electricity, why we have the LVH. It's depending where you have the leads. You will see on the precordial leads and the V1, V2, S is going to be, they are going to be very deep, and then when you go all the way down to the left ventricle, you will see the R are going to be very wide, upright. Okay. So this patient is a young man that was complaining of vomiting and diarrhea after he was doing a Disney marathon or making a run or a marathon of 20 kilometers. Patient has an EKG, and this EKG looks like little weird. Oh my God! So I need to figure out, does the patient has an MI or not? Okay, this patient will have this deep ST depression on the inferior leads and also the lateral leads, in addition a little bit of LVH. And the LVH is because of the big S and the big R on the precordial leads. There's something called the athlete heart. So sometimes a person who runs every day or makes a long marathon, you will have this weird EKGs per se. So when you see something like this patient is associated with, usually because of the repetitive cardiac tachycardia of this patient, the loading when the patient is making a lot of exercise, and this patient may have a resting tachycardia where these guys are going to be running, and usually their pulse is around 130, 140. If I run from here to there, my pulse will be 200 because I'm in very good condition. And then these people, when they're resting, these guys are usually, or girls, they will have a heart rate around the 50, on the 60, and that's normal for them. Anything that excites them, like when they do any activity, the pulse will be a little higher, but nothing like in the real population where you have a pulse of above 200, above 180. And these people usually may present with a little bit of bradycardia, they may have cardiomegaly, and this may have some cardiac hypertrophy. And that's why you see this type of EKG where where you see these big R's on the precordial leads on the lateral leads, and then S waves on the precordial leads on the anterior leads per se. Believe it or not, what we do for this patient is cross your finger, nothing bad happened, let's go to the ER. Okay? Okay. Now, this is, again, this is an example of this type of patient where you have a normal pattern, okay, versus the patient who has what I call the athlete heart, okay? So these people will have a patient who has LVH on, like in the first case that we talk about, we have a big S wave on the precordial leads, on the anterior leads, and then you have big R waves on the lateral leads. And this is usually a patient who has LVH, and versus the athlete heart, you will see that in a resting, all those changes that we saw earlier are gone. So now, if you have here a patient compared with a chest pain and you see something like this, do I need to worry about this patient or not? So again, you know, the poll said that you had to figure out, do I call it STEMI or not call it STEMI? So most of you guys seeing something like this is a typical MI. So where's the MI at? Of course, in the heart. Yeah, we know that part, okay? But which part of the heart? It's the anterior part, the inferior part, the lateral part, the septal part. So let's review a little bit about anatomy. Okay, so in this case, where you have the S elevation on the inferior leads, it will be 2, 3 ABF. You can have the MI or either on the RCA or on the LAD. And let's go a little bit about anatomy, like I said, okay? So you have hyperacute T changes. Sometimes when you come here with a patient with a STEMI, you will not may see the S elevation. You may see some T changes, and I'm going to show you a couple of T changes that you have to worry about. ST segment elevation, that's the typical ST elevation, MI. Sometimes you will see T wave inversion, and still, T wave inversion, but that's not ST elevation. How come that's an MI? And I'm going to show you which type of MI a patient may have a T wave inversion. Significant Q waves, usually when there's necrosis, already that part of the heart is all damaged, that there are irreversible changes per se. Transmural MI and anterior MI, you will see usually which artery is occluded, the LAD, the left anterior descending. Usually you will see S elevation on B1 to B6. You may see inferior reciprocal changes, that means ST depression 2, 3 ABF. You may have ST elevation in the anterolateral, B1 to B4. When you have an anterolateral MI, you will see this patient have an MI or an occlusion on the LAD or the anterior trunk of the artery. And usually you see ST elevation in B3 to B6, 1 and AVL. Inferior reciprocal changes. On the lateral MI, you will see the ST elevation more in V5, V6, 1 and AVL. Okay. And usually it's in both the left circumflex or the diagonal branch of the LAD. And you may see inferior reciprocal changes also. Now, when you have an inferior MI, you will see the EKG change in 2, 3 ABF, and you will see reciprocal changes on the lateral side of the wall. 90% of the inferior MI is usually caused by the RCA, 10% is the LAD. Always consider possibility of concurrent posterior or right ventricle involvement. So why is that? Why do you need to worry about if the right ventricle is involved? So what happened? One of the medications we give patient who has an MI, we gave what the supported oxygen, morphine for pain, aspirin, and so I mentioned nitro. So what happens if the patient has an inferior MI and it's involved the RCA and I give nitro? What can happen? We cause hypotension, okay, because the filling effect to the right ventricle is decreased, and you give nitroglycerin. Nitroglycerin decrease the venous return, cause vasodilatation, and then the blood flow would not go to the right side of the heart, causing hypotension. Okay. Posterior MI. In posterior MI, remember earlier we talked about some T wave inversion. On posterior MI, you will see a large R wave, and instead of the ST elevation, you will see ST depression or T inversion B1 and B2. And I'm going to show you some EKG explaining how you can see this, or what they call the mirror image of the septal MI. Okay. RCA and left circumference is the most typical causes for the posterior MI. Okay, so following the anatomy, so We have the RCA, LCA, this is the LAD, left circumflex. Then the LAD, you have a diagonal branch that can cause the MI on the lateral part of the heart. As you can see, the inferior aspect of the heart is vascularized by the RCA and the LAD. The anterior part of the heart is vascularized by the LAD, as well as septal, and the lateral part of the heart is left circumflex and LAD. As you can see in the posterior part, you have an RCA and you have the left circumflex. These are the different type of EKG changes you will see when the patient is having an MI. As you can see, sometimes you will see some T inversion first. That's when the patient starts complete chest pain. And when the patient, the occlusion is causing more hypoxia on the tissue of the heart, it starts causing the ST elevation. Okay? And when there's necrosis, already the patient will have Q waves. Again, examples where you start ST elevation a little bit, and then when the patient continue with the MI, we'll have ST elevation. And when you have necrosis, then you will see the formation of the Q waves. Okay? So, again, different type of EKG changes. So let's try to give you some cases here. Okay, bear with me 1 second. This is the same slide that we talked about earlier. Just to review everything. Okay, so if we have an inferior MI, you will see ST elevation in 2, 3 AVF, okay? And 2, 3 AVF, this is the apex. So it will be this area here, which vessel will be involved. So usually it's involved the LAD and the RCA. If we have the anterior MI or the septal MI, usually the ST elevation you will see in B2 to B4, okay? And it will be this area here. And which vessel is the LAD most of the time. And then if you have the lateral MI, you see ST changes in 1 AVL B5 B6. And which part of the heart? So this is the lateral part, and we say lateral part is the circumflex or the LAD. Okay? So remember the first case that we talked, this is another case, sorry. This is a patient came in with chest pain, and I call STEMI on this patient. And you say, why I call STEMI on this patient? I don't see ST elevation. Okay? The reason for this is because of this T inversion first. Okay? Sometimes, I showed you some diagram earlier that patient may have complaint of chest pain where you have an inverted T waves start first, and that inverted T wave then is going to convert to ST elevation. And so inverted T waves here, and then 2 hours later, what happened with that inverted T waves? So we had it like this, and what happened then? It turned to ST elevation. Okay? So why 2 hours? Because I called the STEMI at 12:45. Okay? And when I called the STEMI at 12:45, I called the cardiologist. The cardiologist said, well, the patient does not have ST elevation. Sir, patient's having chest pain. Sir, patient, the troponin is high. Sir, have this patient T changes. This is going to the ST elevation. Yeah, but it's not ST elevation. So guess what? Patient still complete chest pain. 2 hours later, okay, so ST elevation. So that means that the patient was in my ER sitting for 2 hours, okay, and nothing was done. Okay? Remember, we have up to how many minutes to door to balloon. And door to balloon means is when you guys contact the patient on the street or in the house, etc., to angioplasty. It's 90 minutes. So this patient is already out of the window. Okay? So it's very important just trying to review, okay, what are the ST changes you can find in certain type of MI. And that's why it's important for you guys to see a lot of EKGs. So I'm going to show you more EKGs about this, okay? So on this case, patient may have an anterior MI where you will see the ST elevation usually in B1 to B4, and sometimes only you will see in B3 to B4. Lateral MI, usually ST change you will see in 1 NAVL, and B5, B6, 1 AVL, B5, B6. Anterolateral, patient may have EKGs from B1 all the way to B6, as well as a 1 and AVL. On the inferior, you will see ST elevation in 2, 3 AVF, and the reciprocal changes. Through posterior, you will see a big R. Usually, earlier we talked about the V1, V2, usually you see S wave, you don't see R wave, because the electricity goes from here to here. If the electricity goes this way, this part here, the R wave is going to be negative usually. Why? Because the electricity is going away from the superior part of the heart. If you see R waves in V1, V2, start thinking about, does the patient have an MI or not? Okay, so born EKG, inferior MI, 2, 3 ABF with reciprocal changes, okay, in 1 AVL. Inferior lateral MI, 2, 3 ABF. You have ST elevation V5, V6 lateral, but also has reciprocal changes, a little bit of reciprocal changes, especially on AVL. Anterior MI, where you see ST elevation V1 to V4. Anterior inferior MI, little bit of ST elevation 2, 3 ABF, B2, B3. But again, reciprocal changes. What happens if this ST will be up? So you still think about MI or think about something else? Start thinking about, does the patient has pericarditis? Remember we said earlier, pericarditis you have diffuse ST elevation but no reciprocal changes. And I'm going to show you some cases like this. Okay? Anterior lateral MI, septal MI, where you have the ST elevation V1 to V3. Inferior septal MI, ST elevation in 2, 3 ABF, V1, V2, okay, and V3. And then you have reciprocal changes, okay? And then the posterior MI. So earlier I said that posterior MI, you will see ST depression in V1, V2, and you will see the R wave in V1, V2. So you will see me sometimes when they show me an EKG, what I do with EKG. I go crazy and turn it backward and put it upside down. And you're like, that doctor is crazy. No, because I'm going to try to see if I see ST elevation. So how I do this? So you have this EKG, okay? So what I do is I turn it backward, and when I turn it backward, what happened now? Look at the ST elevation here, okay? This is V1, V2, V3. So what I try to do is, if I look at the EKG this way, what I do is turn it backward and upside down, and this is what you see, okay? And that's why sometimes when I see something weird in V1, V2, you will see I'm playing with EKG, going backward and going upside down, like that doctor is crazy. No, I'm trying to look this, okay? That's what I'm looking for, okay? So this is a posterior MI. Okay. So you give aspirin and the nitroglycerin and nitro, and the patient becomes hypotensive. And like you mentioned earlier, what happened in this type of patient? So most likely the patient has an RCA, the right ventricle, patient may have a right ventricle MI, causing there's no good blood return, and because there's no blood return, they're unable to push the blood out of the heart. Why? Because the right ventricle is not working. If it's not working, it's not feeding. If it's not feeding, if you give nitro, patient becomes hypotensive. So how you treat this? What you give this patient? So what we do usually when you have hypotension, we give what? IV fluids, okay? So you give IV fluids, okay? So remember the first EKG that we talked about? So you see the ST elevation 2, 3 ABF with reciprocal changes, okay? Think about, remember inferior MI can be caused by the RCA on the LID, but we say 90% are RCA. So we have to be careful if we give nitro, and if one chance we get nitro, the patient becomes hypotensive, then start thinking about what happens. So we get too much nitro, dehydration, ruptured aorta, or feeding defect. So most of the time it's feeding defect. Why feeding defect? Because the right ventricle is not getting full of blood, and it's not able to push the blood out. Okay? So patient have what they call a right ventricle MI. So right ventricle MI, blood pressure would drop with nitroglycerin. Usually these people, when you auscultate, the lungs are clear, and what happens? Patient have big JVD. Usually it's because of an RCA occlusion. Do a right side EKG. How you treat the hypotension? You give IV fluids or dobutamine. Okay? So this is the right side EKG of that patient. So the same patient we saw earlier, what I do is, instead of put the EKG this way, I do the V1, V2, V3, V4, V5, V6, and you will see, usually in V4, V5, you will see ST elevation. Okay? So this is what I call a right side MI or right ventricle MI. Okay? Okay, so all the EKGs change to just MI. So you have a 46 years old, chest pain, male, and this is the EKG, and what I did, I called STEMI. By the way, these are EKGs of mine. Look, those who knows my signature, this is my signature, so those are my EKG. So it's not like I'm making up cases from, I go Google, let me go Google and research here, okay? So these are real patients that I had, okay? So why I did call STEMI on this patient? What was the reason I called STEMI? Any idea? Anything weird that you see in the EKG? Okay, first we don't see ST elevation, okay? But I still call it STEMI. There are some waves, some weird waves were in AVL, okay? So when you start seeing something like this AVL here, okay? When you see this ST or T depression AVL, you may have a patient who have an MI, okay? And this can be an early finding for an inferior MI. So this is the same patient, sorry. So this is the same EKG, the same patient, and look at the EKG now. So this is, I don't remember, it was like maybe like 10 minutes later, 15 minutes later. So we have this EKG first, okay? Look, this change here, but 2, 3 AVL looks fine, okay? Then 10 or 15 minutes later, we repeat the EKG, and look what's going on. The ST depression is getting worse, and here, look at the ST elevation, a little bit of ST changes here on the inferior leads, okay? So if you see an isolated ST depression or T inversion AVL and patient compared chest pain, again, I don't expect you to call STEMI, but I expect to you just, let me just go instead of 50 miles, let me go like maybe 65 miles per hour, okay? Okay? Or maybe, should I give nitro? Should I do something else, okay? So just be careful. If you see T inversion in AVL, start thinking about those patients maybe have an MI, okay? So inverted T waves in AVL, okay? So again, inverted T waves in AVL, oops, sorry. Usually exception, when do you see this also in LVH and left bundle branch block? Okay? Otherwise, it should not be there. Okay? Next case. So this patient came complaining of chest pain, was seen by one of my colleagues, discharged the patient. This patient was seen, the EKG was seen, as you can see, my colleague write a little line here. Why? Because he thought, maybe it's an ST elevation, maybe there's something going on, but he documented it was only in one lead and there was nothing else. Okay? Patient was discharged. Patient 2 hours later came back dead. Okay, not dead. Came in cardiac arrest with the EKG, and the EKG of the second patient shows. Oops, sorry, it's not there. I thought it was there. But I reviewed the EKG, and if I saw the EKG in the beginning, I would call an MI. I would call STEMI. And why is that? Because you have ST elevation in B1. Okay. Remember we said B1 is negative. What I mean negative is all the waves should, but the P wave, or the P wave can be up, but the QRS and the T should be negative reflection because the electricity go from here to here, so if we're going away, the wave should be negative. You can see here that the wave is going up, it's not going down. So when you see T waves in B1, this EKG should be earlier, but this is the EKG. This is the same patient. Look at what happened with the ST elevation now. Okay, so first it has something isolated here, a little bit of T inversion on the first EKG, and this is the second EKG, and look what happened. Now it has ST elevation on the anterior leads in B1 and B2. Okay, so T wave in B1 is normally flat or inverted. Usually that's what the typical T waves in B1. Occasionally is upright. In what situation? Usually in a young person, usually it's normal, but if you see in a old person, usually it's not good, okay? So if you have someone who is 70 years old compared to chest pain, and you see an inverted T wave upright, not down, upright, that is abnormal, okay? Usually it's associated with the left circumflex or RCA disease. Also, you will see an LVH, like we said earlier with the AVL, and left bundle branch block. So as you can see, LVH and left bundle branch block is going to be present in almost every EKG, okay? But just be careful. Again, we talk two types of EKGs. We see the one with inverted T waves in AVL, and we talk about the upright T waves in V1. Brugada, we'll talk about Brugada later on. Pulmonary emboli can cause this also. Okay, 28 years old, male, complaining of chest pain and shortness of breath. This is EKG. Anything weird? Should I call STEMI? Should I do nothing? Should I just cross my finger? Okay. So patient was discharged with a diagnosis with early Repo or versus pericarditis. Why they call it pericarditis? Because it has this ST changes, like little bit of elevation diffusely. But we said earlier that pericarditis has diffuse ST changes or elevation, but should not have what? Reciprocal changes. What happened here on AVL? There's no ST elevation there. So the guy was discharged, okay, and was told to follow the cardiologist. Patient returned by ambulance complaining increased chest pain after collapsing. And this is the case of the same patient now. So what's going on now? So now the ST elevation is more pronounced, and you have a little bit of reciprocal changes more pronounced here. Okay? So the patient has an MI in the first EKG. Why? Because pericarditis would not cause reciprocal changes, would not cause ST depression. Okay? So pericarditis, that's not. What I mean pericarditis that's not, it's not pericarditis, okay? So pericarditis had to have diffuse ST elevation, but no reciprocal changes, okay? So I review the first EKG. So that has this weird reciprocal change there. Pericarditis does not have reciprocal changes, okay? Pericarditis, this is an example of pericarditis where you have diffuse ST depression, okay? Look at this, diffuse ST depression all over the place. And also you will see something called a PR depression. In this EKG, you are not able to see it, but I have another case where you can see the EKG better. Okay? Depressed PR. Okay, next case. 53 years old, chest pain, female, shortness of breath, has something like this. I'm like, oh my dear Lord, what's going on? So I call it STEMI. Why I call STEMI on this one? Do anyone knows which one is the forgotten lead? Which one is the forgotten lead? Which one? AVR. Why? Why we call it forgotten lead AVR? Because we don't care. It's like, why AVR is there? So AVR is in this side here, okay? Like V1, AVR should be negative, okay? But if you see on EKG where you have ST elevation, or it doesn't have to be ST elevation, like upright of the ST, most likely there's something wrong there, okay? Look on the AVR here, okay? So this usually in a normal person, it should not be like this. It should be negative deflection, okay? I call STEMI. Why? Because of this, okay? ST in a ST elevation AVR. Now, that's what we call the forgotten lead. Usually it's a left main arterial occlusion. If ST is elevated in AVR, in addition, consider LMA occlusion versus LAD occlusion. Treatment is PCI. Nitroglycerin is not going to work. A thrombolytic will not work. So this patient is because the clot is so high on the left main or in the LAD. Usually blood thinners or thrombolytics are not going to work, so this patient needs to have a hard cut, and sometimes they have to have a cabbage. Okay? So the other name for the forgotten lead when you have this type of EKG on AVR is the widowmaker. Why? Because no one recognized it and the patient died, and that's what they call a widowmaker. Okay? So lesion in the main LCA or proximal LAD can have severe consequence causing the widowmaker. Okay? LAD supplies the anterior wall of the heart, including both ventricle as well as the septum. Okay? An occlusion in this vessel can cause kaput. Okay? Okay. Next one. 52 years old, complaining of chest pain. Okay, so I call STEMI. Why I call STEMI? I don't see ST elevation. Any idea why I call STEMI on this one? Anyone heard about Welland syndrome? Okay. So Welland syndrome is you see a biphasic changes in V2 and V3, okay? Where you see something like going up, but then it goes down, okay? Welland syndrome, and the criteria. Patients have complaint of chest pain, prior history of chest pain. Patient may have an EKG that was normal, and then it turned to this. Patient may have ST segment in V2, V3. Refer to this specific EKG changes where you have the biphasic way in V2, V3. Specifically, it has to be V2 and V3. Usually, it's inverted biphasic in with V2, V3 is a critical stenosis of the LAD, descending LAD, okay? And this patient may have an MI because many people do not recognize this, and the patient may not die, okay? Extensive wall MI. Okay. Usually it's increased LAD stenosis, and this patient require invasive therapy, like we said in AVR. Usually when you have AVR elevation, usually thrombolysis is not going to work. In these cases, patient need a hard cut because most of the time the thrombolysis are not going to work. Okay, but that's why they say that it's poor medical management. Okay. Next case. This is one that you discovered. I didn't discover. Someone discovered this many years ago, but I discovered me reading about it maybe like 5 years ago. Why I called STEMI. This is an case from one of you guys, EMS. So came in with chest pain, they came through the door, they showed me your 12 lead, and I called STEMI. Okay. It's called something called the winter syndrome. Okay. Oops, sorry. The winter. New sign is proximal LAD occlusion. It's called the winter STEMI. And you will see an upslug in 1 or 3 millimeters ST depression on the precordial leads. Usually B1 to B3. Okay. Normal STEMI morphology may precede or follow the winter pattern, found to have proximal LAD occlusion. Okay. So this is something like this. Okay. We see a little bit ST elevation here, but also ST depression. So ST depression first, and then ST elevation. And usually in precordial leads. The winter. Anterior STEMI equivalent that present without obvious ST elevation. Includes ST depression and peak T waves on the precordial leads. And I've seen 2% of the LAD occlusion. Okay. Patient start complaining of chest pain when suddenly this is another patient. She collapsed and has something like this. So this is another EKG of my patients. Patient was in triage, came, patient collapsed, started seizing, and they did an EKG, and the nurse said, oh, mama, patient is having seizures. No, I don't think so. So what is this? Torsade, okay, so torsade. So she's having a seizure? No. Someone's tickling her, maybe she's tickling, having, laughing, ha ha ha. She's dancing, they break dancing, nah, so torsade, very good, okay? So what's the trend for torsade? Okay, so of course we think about max sulfate, okay? But ACL said that we have to do first what? Check for pulse, and if there's no pulse, do what? CPR. While we are looking for, come on, a defibrillator, no? Remember we have to check this patient, okay? Okay, so what we're doing, anticonvulsant, stop tickling her, defibrillate, okay? Max sulfate. Well, so torsade. Torsade can be secondary for a certain medication, and also can be caused by an MI. So this is the patient after we shock the patient start waking up, but this is the EKG after we shock the patient. So this patient start having ST changes on the anterior lead with reciprocal changes. Remember we said earlier about this damn AVL. Be careful of the AVL. Okay, so you see T inversion AVL, think about, does the patient has an MI or not? Okay, next patient, chest pain, irradiated to the left side, blah, 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 and has something like this. Sorry for the EKG. Okay? This is the EKG when I was in my residency. We didn't have the iPad or the iPhone that can take pictures. Like, you know, you have the EKG and you have to like take, like a monkey, you throw the picture like that, and then you have to scan it. So this, you know, this is one of those EKG, old EKGs, okay? So left bundle branch block, okay, where you have a wide QRS and you see a little bit of S elevation. And I don't know if you're learning this, but when someone has left bundle branch block, you are looking for what criteria? The criteria of what? S garbosa. Very good, garbosa, okay? So this is the same patient, okay? So this is patient EKG coming to the ER. This is, I was lucky to have an old EKG, and this is old EKG. So this patient has left bundle branch block, but what happened with the ST changes? Oops, sorry. There's profound more ST elevation here than in this one, okay? Now we have the pharmaceutical garbosa criteria, where you have, these are 3 criteria, but of those 3, one of them is going to be removed, okay? And this one is going to be removed. So usually you look something like this, or look something like this, okay? So 5 years ago, we were using this. From ACLS 2015, 2016, now we're using this, okay? This garbosa criteria, okay? Next case, chest pain, blah, 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 shortness of breath, etc., etc., etc. These are the vital signs, okay? Blood pressure 0 high. Lungs are clear. Circulation is fine. No edema. Everything looks fine. But this is the EKG. So what's wrong with this one? The question is, does the patient have diffuse ST elevation? Okay, it does. Okay, has diffuse ST elevation. The question is, if this is true or not true. So this is one of those cases that can be pericarditis, but it can be an MI. Okay. So diffuse ST elevation. Okay. With happy face. Remember about the happy face here? Okay. Happy face. No reciprocal changes. Some of you guys may tell me, oh, what's going on here? Okay. So the question is, does the patient have pericarditis or not? Okay. But this patient has something called PR depression. So PR depression here, PR depression here, PR depression here on this arrow. Okay. And that's why it goes that's why it was called pericarditis. Okay. So just be careful. Okay. Happy face, smiley face. Okay. Versus sad face. Okay. 20, last case that we're going to talk about because of the time is 20 years old with syncope. I didn't call STEM on this one, but I admit this patient. Why I admit this patient? Not because she passed out, but anything weird on this EKG? What happened with the right bundle? Look at it, there's in B1, the right bundle, what they call the right bundle branch block, is a wide QRS, and there's a little bit of elevation here. And that goes with a new condition. No, it's a new condition, but something that we're worried more, that when I was when I did internal medicine residency 20 years ago, we didn't care about. But now we care about it. Something called Brugada. Remember about Brugada? So patient was discharged. Patient returned pulseless, okay, on VTAC. And that's what happened with Brugada. Okay, there's 3 types of Brugada. Okay, the patient, the EKG that we saw was something like this. Okay, and this patient most likely had to have an external defibrillator or an AICD or an internal defibrillator because they can develop VTAC. Okay, so different type of Brugadas. Okay. More common cause of sudden death. When I was in 20 years ago, people who collapsed and died, we thought was NMI or something like that. Now it's a more electrical conduction prone in Brugada, and it's very high, it's 4 to 5%, so be careful. Someone who is a young person, pass out, and you do an EKG, and you see right bundle breastbone, just be careful, okay? Don't tell, yeah, there's nothing wrong, you know, stay at home, you know. Someone pass out, you do an EKG, the EKG looks perfect, that's fine. If the EKG looks weird, just be careful, okay? Just because of the time, I'm done here. There's 10 more cases that are going to present next Thursday, so you are welcome to come. And it will be in Osceola for the, it will be a series of, we will have 4 hours in the morning, where we will have Dr. Dalton, the director for EMS for Osceola. We'll have Dr. Hunter and Dr. Husty from Seminole County to continue talking about EMS from you guys, because this week is from you guys. This is the EMS week, and I congratulate and I thank you very much for your work, for everything that you're doing. Okay? Any questions? So I will be around here for any other question. Thank you very much.